Hello, and welcome to the Taking Control of Your Diabetes podcast. I'm Dr. Steve Edelman, and I'm not here today with my good co-host and close friend, Jeremy Pettis, but I am here to discuss a very serious issue called frozen shoulder. And with me is a good friend and colleague, and very importantly, the ultimate physical therapist that has helped me get through my frozen shoulder and recently my knee replacement. That's not the topic of today. Reece Jensen. Reece, tell us something about yourself.
Well, I'm happy to be here. Yeah, I'm a physical therapist. I went to Boston University, got my DPT. I've been a physical therapist for almost 34 years, and I've been with PRN, Physical Rehabilitation Network, for the whole time.
And that's a nationwide organization of physical therapy sites.
Physical therapy clinics, yeah. It started in my office in Encinitas, and now we have several hundred in 7 or 8 states.
Yep.
So we've grown a lot.
Well, before I ask you the very first question, I think I just have to say that having a good physical therapist that is smart and knows the mechanics around your injury, whether that's your shoulder, your hip, your knee, is somewhat important, and you have really helped me quite a bit. I really appreciate that.
My pleasure.
Okay, let's talk about frozen shoulder. What is it, and what causes it?
So they don't know exactly what causes it. They think it has to do with glycation, where the glucose and ligaments become sticky, and it is a insidious onset. So it happens for no good reason. The body makes a mistake. So let's say you lift something and you felt a small pain in your shoulder, or you bump your arm against a door jamb, or do a few more reps than you should at the gym, and your shoulder's sore. Normally, a normal situation is a few days later, that goes away. But when you develop frozen shoulder, over a period of a couple weeks, it turns into a very painful, very limiting condition where you can't touch the top of your head, you can't reach your other armpit, you can't put your hand behind your back, because the capsule, which holds the shoulder together, has gotten very sticky, and all those parts have now gotten stuck together. And that's a painful, challenging condition.
Yeah, I can attest, as I've had it twice, but 10 years apart. Well, give us some...
That's the statistic, actually. You're about 16% more likely to have it. If you have it in your right arm, you have a 16% chance of having it also in your left arm at some point. Again, we don't know why, but it's just the stat.
Well, give us some more stats, like how much more likely is it for men versus women? And does it matter how long you've had diabetes, type 1 or type 2?
Well, 58% of the people that get frozen shoulder are female. There's about a 2% prevalence in the general population, but for diabetics, it's 13.4%.
Yeah, that's
so
huge.
It's a much bigger number of people that are getting it than in the general population.
Yeah. Now we talked about this a little bit before, but both of my situations, I don't remember any trauma. But, my control may not have been that great. And this last time it was probably a lot better. But nonetheless, what are kind of the early symptoms where someone could say, hey, I think I heard that podcast, and I think I might have the beginning of a frozen shoulder while I treat my blood sugar that just went a little bit above 150.
It's because you're so nervous.
No, not really. I'm past the painful part we're going to talk about.
Well, so if you do something and you have a sore shoulder and it doesn't resolve in a couple of days and it starts feeling worse for no good reason, and you start being unable to lift your arm above shoulder height, or have aching at night and you can't sleep on that side, if you notice that within the first 7 to 10 days after the pain starts, you should go see your doctor, because the quicker you can get in and get a diagnosis and start treating it, the more likely you are to avoid the year-long course that some people have to go through.
Yeah, and that was my case because I developed it right during COVID. I didn't realize that your office was open. Everybody else was closed. I know you're still putting kids through college, so you had to stay open. And I'll tell you what, I can kick myself for not saying I need to go see Dr. Jensen, because I probably lived with the symptoms 6 to 9 months. I try to do, exercises on the internet. And the other big lesson I would like to tell listeners, and you know this, it's impossible to do this yourself. But before we get into therapy, what other motions would someone have a hard time doing? You mentioned raising your hands above your head. And I know I always had this thought, if I ever got arrested for drinking and they put me in handcuffs behind my back, I would die.
Yeah, that's probably the worst one. That's a combined motion of reaching behind and rotating your arm. So for females trying to do the bra strap, for guys trying to wash their other armpit, reaching up to grab if you're the driver, reaching up to grab your seatbelt and try and grab your seatbelt and pull it down. Those kinds of things. Anything where you're not just reaching directly in front of you or directly to the side, any combined motion or rotation, because all of those tissues become stuck together, it really limits you in the combined motions as opposed to just lifting straight up and overhead.
Yeah, and even putting on a dress shirt, I put my right arm in, but then I could not reach back and put my left arm through the sleeve. So I learned to put my shirt on with my left sleeve first. Now, what about, you mentioned bras. If I was a female, there's no way I could ever put on or take off a bra. And I learned subsequently that you can get bras that unhook in the front. And at least that allows women to deal with that. But there's no way I could have done that.
Yeah, it makes those kinds of things really tough. Putting it on in front and spinning it around, and you're basically doing kind of a shimmy dance to get your clothes on in the morning because you don't have that shoulder motion. And it's painful. It's not that you just can't move it there. It hurts.
Yeah.
And it hurts because you went through it.
So what's a typical way you make the diagnosis?
Well, the physician will make it based on your loss of motion and the pain that you're having. And they can also do an MRI, which will show the tissues that are stuck together in the shoulder. There's a pattern of connective tissue that they can see on the MRI that says, okay, this shoulder's frozen. But I can make the diagnosis, and I have, just by putting someone through the motion and feeling their shoulder. When the humerus bone does not glide back and forth normally, when I grab your shoulder and move it, I can feel the capsules stuck together, and that's where you're right. You couldn't do it yourself. I couldn't do it to myself because I need a separate pair of hands to move those two structures independently.
Yeah, it's very hard to do these things yourself when it causes pain, and I would say this, Reece, that there are a lot of doctors that don't know SHIT about frozen shoulder, and there's some that do, but most orthopedic surgeons would have a pretty good idea of what it is. And I think for you, and I'd say the physical therapy profession, in all the years I've used them for my different joints, is you can make a diagnosis on physical exam like 95% of the time, and especially someone like yourself with years of experience, So when I came in to see you and someone else comes in with, you're pretty sure it's a frozen shoulder, you have the MRI or other diagnostic criteria, and what's the plan of therapy?
Well, first we want to assess, what your functional loss is, what your range of motion loss is, take the measurements, test your strength, see if there's anything else maybe going on, if you've injured your rotator cuff in the initial injury perhaps. Are you osteoporotic? Is there anything else that might make it difficult for us to do our job safely to get your shoulder moving? So we first assess all that, and then we come up with a plan, which in your case was to try and do joint mobilization, where I move one bone relative to the other to try and improve that joint mobility so that you can then lift your arm up. And while you wanted it to work and I wanted it to work, your muscles were fighting me because of the pain. So I have a tight joint and I have your muscles fighting me and I'm fighting you. And that's a recipe for disaster. That's when, a therapist that tries to do that and be a cowboy ends up with a torn rotator cuff or breaking somebody's humerus. So there's a point where we go, okay, we're not going to get to do this conservatively. And that's when I told you to make the next step.
Well, describe the next step.
So if someone doesn't have a problem with steroids, you can do a injection like your doc did for you with steroid and Marcaine, and then within an hour or two of that injection, come into the clinic, and you're less painful, and we have that steroid in there. So when I mobilize your shoulder, there's not going to be a lot of swelling, and that's what worked for you. I was able to break your adhesions free safely, and while it was, as you have said, the most painful thing you've ever experienced, within a few days, you realize, oh my gosh, my shoulder is moving. And the pain got better. And we, over a period of another 4 to 6 weeks, we got most of your motion back. If you can't do injections or you have other issues with that, you can do oral prednisone tapering dose pack. That'll help with the inflammation as well. If that doesn't work, or if that's not an option, then or your pain threshold is too low to deal with me stretching your shoulder every time, then you can go into your surgeon. They'll put you under anesthesia lightly, and while you're out, then they'll manipulate the shoulder. Because again, the muscles aren't fighting, and you're not aware of the pain, so you're not going to be guarding. And they manipulate it, and then they send you right into therapy to keep that motion. Yeah.
Now, I'll tell you what, Reece. I tried on my own for quite a while. And even working with you, there's only so much you could do because it was so painful. And then when I got that injection by Dr. Robertson, I got to your office, and you just say you were able to manipulate it. To this day, it is the single most painful thing in my life. And I heard it, and you heard it. It was just like a rip and a tear. And I almost passed out from the pain.
Yeah, you were pretty pale.
And yeah. I'm pale anyway. So, and then the pain didn't bother you at all. You were happy.
Oh yeah. When I hear that sound, I know that within a couple of days, you're going to be feeling so much better.
Reece, I felt better leaving the office that day.
Right.
The pain it's important for you to tell everybody, the pain didn't last long. It was just instantaneous pain.
Right.
And it went away quickly. And you asked me if I was okay, made sure I didn't stand up. But it made the whole difference in the world. From there, it was, I'd say at this point, complete recovery. Right. And I'm able to do a lot of things I couldn't do before. And it did take a while with exercising and hanging from a bar to get. I could never even think about doing that before.
Well, now, you dealt with it for so long that you'd had some atrophy, and so just the motion wasn't the end of the story. We had to get your strength and your function back. And I want to say that the manipulating a shoulder is not something I do very often. It's pretty rare. It has to come down to the patient agreeing to do it, the surgeon or the doc being okay with it, and me knowing there's no contraindications that I'm going to injure you. Right? I had the good fortune of being in the operating room with an orthopedic surgeon friend of mine to manipulate a couple of my patients that weren't getting better. So I got to see how it was done. I got to feel how, pre and post manipulation and what that sound was, so I didn't freak out. So I have a lot of experience in that particular diagnosis and treatment. So it's not something every therapist would want to do or will do or should do. But if you go to someone who's an orthopedic certified specialist, an OCS, they should have a lot more experience and background to be able to do that if it's indicated.
Well, you mentioned something else earlier, that if you don't know the right type of manipulation, you could actually cause a rotator cuff injury.
Yes.
You maybe can explain that. And you said something else with a humerus. Humerus is your arm bone.
Yeah, your arm bone. If I have an older female and she might be osteoporotic or rheumatoid arthritic or someone with lupus where they may have poor bone health, then that makes it a contraindication. I don't want to end up, breaking someone's humerus trying to get their shoulder motion. That's just going against everything we're trying to do.
Then you need a good lawyer, right?
Yeah.
Well, in terms of recovery, it sounds like there's a lot of variables depending on how long you went with symptoms before addressing therapy. But typically, like you said, the next 4 to 6 weeks, you can get back to functionality, maybe not 100%. And why is it that you can get, why a frozen shoulder can occur 10 years apart, but also you mentioned, and we talked about this earlier, that if you have it once, at least you can be pretty comfortable with it not happening again.
Yeah, it doesn't usually happen in the same shoulder twice. It usually will occur in the other shoulder, 5 to 10 years apart from the first one. So for some people that have had a really challenging first frozen shoulder, where they maybe had to have injections and manipulation or even arthroscopic surgery to release everything, that's pretty scary. Oh my God, it's happening in the other shoulder now. I got to go through this all again. But that's their genetics. So you can't totally prevent it. You just have to know, okay, well, this is what I have to do to get through this one.
Yeah.
And you only have 2 shoulders, so then after that, you're done.
Well, that's good. Well, I could knock on wood here, but I had my right shoulder over 10 years ago, and that never came back, and then my left shoulder 3 years ago, and that never came back. What other conditions do people with diabetes who get frozen shoulder have? Are there other conditions that sort of are also seen when someone gets a frozen shoulder?
It depends on their general activity and fitness. So if they don't really exercise or use their arms for much, then they could have relatively weak scapular stabilizers and rotator cuff muscles that during the course of this could get even weaker. So it may be hard for them to get back to doing, putting dishes up on shelves and cleaning and doing things, lifting things basically, because they already had kind of a weak shoulder or rotator cuff dysfunction, and now they have the frozen shoulder on top.
Reece, let's talk about the natural history of the frozen shoulder. Now, I've heard you talk about, freezing, frozen, thawing. We're not talking about making a daiquiri. I want to talk about the shoulder, but I like those analogies.
Right.
Because frozen is in there.
Well, the real term is adhesive capsulitis. That's the medical term for it. But people call it a frozen shoulder because it's not moving. So in the first 7 to 10 days after whatever injury or sleeping funny on your arm, whatever happened, it goes into the freezing stage where everything gets sticky and sticks together, just like the pleats on your shirt. If I stuck the pleats on your shirt to your side with a staple, you wouldn't be able to lift your arm and it would hurt. That's kind of what happens to those little pleats. So that's the first stage. Then there's the frozen part, and that can last several months, up to 18 months. And we don't know why it starts. And in the same token, we don't know why sometimes after 12 to 18 months, it just goes away on its own. And then we call that the thawing period, where either you've gotten treatment and the adhesions have released and you're getting your motion back, or the body just decides it made a mistake, my bad, and it takes away the adhesions and you go back to motion.
Yeah, well, my very first frozen shoulder, I did not get therapy for it, and it took 2 years to go away. It was miserable.
Yeah, it's a lot of loss of motion and function over that time. So early intervention is really important to figure out what you have and what the best path is.
That's probably true with any condition, heart disease, blood pressure, diabetes. The earlier, the better. Well, what about, you probably don't have an answer for this, but I know a lot of listeners are probably thinking, what could I do to prevent having one? And I don't know if you have an answer for that, or there is an answer for that, but I might as well ask you.
I don't think there's not a real good answer. Obviously, if you're engaged in activities that challenge the shoulder, like if you're gardening and you're using a pick and shoveling and lifting heavy stuff, and you're diabetic and maybe you're not in the best shape, that's a chance to cause an injury in your shoulder, which then could trigger that frozen shoulder syndrome. But you can't prevent it. If you have the genetics and you unfortunately happen to be diabetic or sugar normal, you may get it, and that's just part of it. And you can't really totally prevent it, just like you can't prevent other stuff from happening in your body either.
Well, my final suggestion, having lived through this twice, is when you start getting a pain in your shoulder doing certain activities, like for a female, putting on your bra, because that is very painful, or a guy putting on your shirt sleeves, right? And then when you hook your shoulder around to get the other sleeve in, if that pain doesn't go away in a couple of days and you don't understand where it's coming from, you should be thinking frozen shoulder. And I think the earlier you intervene, the better off it'll be. The pain won't be as great. You can do the exercises, especially, and live through a Reece Jensen visit. Listeners should know, if you go to his office in San Diego, there's one room it's the torture room.
No, the scream room. And affectionately called.
Reece will close the door so that when I scream, it doesn't disturb and upset the other customers getting treated.
It's for your dignity. We don't want you to feel embarrassed when you're in pain. And so, we have private rooms. We don't make you sit out in the gym and suffer. We take you in the room and do what we need to do, with courtesy and professionalism. But it's not comfortable. It is. And same when you had your total knee, I had to bend your knee. That's what therapy is. If getting better from surgery was easy, I wouldn't have a job. I'd be doing podcasts.
Yeah. And just to remind our listeners that if you're a viewing type of person, you could watch my visit to Reece's office, and where he manipulates my shoulder and causes me real pain. I wasn't acting. And so that's on our website. And also, we should conclude with maybe saying one or two words that you'd like to say. And you should mention PRN again, too, because I think a lot of people could benefit from your physical therapy company.
Okay. Yeah. Well, so if you injure your shoulder, obviously if you fall down, you hurt your shoulder, you should go see your doctor. Don't stick it out. Go and make sure that nothing's fractured and you haven't torn anything. If it's a simple injury and it's hanging around for longer than it should, and you all of a sudden can't reach your top of your head or behind your back, go see your doctor. Try and get in and get that treatment started, get the inflammation down, and get into therapy so you can avoid having the freezing part be really significant and limiting. So I've been in San Diego, like I said, 34 years with PRN.
Get the websites.
Yeah, we are in San Diego. It's www.prnsandiego.com. Our general website is www.prnpt.com. And we do have clinics in multiple states, Nevada, Arizona, Texas, Washington, Oregon, yada, yada, yada. But this was the original location for PRN. And we are a network of physical therapist-owned clinics. So we're not owned by physicians or other entities. We're owned by PTs. And we try and have in all of our clinics the same level of professionalism and ethical care that brings us good results and great outcomes and standing in community.
Well, you obviously love what you do and you're very good at it. So, Reece, thank you so much for joining our podcast today.
Thank you. I appreciate it.